The skeletal system. The skeletal system is made up of all of the bones in the body. You will find in your handbook a full list of all of the bones that you need to learn as part of your Level 3 qualification. So please refer to that and use that as a means to complete your learning for this part of the module. In this module, we'll talk more about the theory, the function, the different types of bones to give you an overview and a framework in which to place the learning of the individual bones.
When describing the spine, we describe it in two groups: the axial skeleton, highlighted here in blue, and the appendicular skeleton, which we'll talk about later. The axial skeleton is made up of the cranium and the bones of the face and skull, the vertebrae, including the sacrum and the coccyx, and the thoracic cage, so the ribs, costal cartilage, and the sternum. Now, you simply need to know that the cranium is the skull. You don't need to know the names of the individual bones of the face or the skull. But there are a number of them that are useful to know because they're key attachment points for many of the muscles you will work with as a sports massage therapist. Clients, so many clients, report with jaw tension. The mandible, the zygomatic bone. We will show you some delicious techniques to reduce the tension in the soft tissues through here. The occipital bone, the attachments into those suboccipital area, tight necks, neck pain. The temporal bone, all areas where there are many soft tissue attachments of stress muscles, neck muscles, jaw muscles. All key areas that you will learn to work as parts of your work as a sports massage therapist.
Now we look at the spine. So here, this is something that you will work with a lot, are the muscles that attach to the spine. So you absolutely need to know the divisions of the vertebrae, how many they are and where they're located. The spine is divided into the cervical, which is the neck, the thoracic, which is the middle back, which you see here, the lumbar spine, the lower back, the sacrum at the back of the pelvis, and the coccyx, the tailbone. Within the cervical spine, there are 7 vertebrae, and it creates a lordotic curve, so it curves this way. The thoracic is an opposing curve, as you can see here. It's what we called a kyphotic curve, and it consists of 12 vertebrae. Then we have another opposing curve in the lumbar spine, which again is a lordotic curve, and it consists of 5 vertebrae. The sacrum and coccyx are made up of 5 sacral vertebrae and 4 in the coccyx, although they are often classed as one individual each, the sacrum and the coccyx. If we take a look at the thoracic cage, we have the sternum or chest plate here, which is attached to each of the ribs via the costal cartilage, which you can see here. There are 12 ribs on each side of the 12 thoracic vertebrae. So it's a good way to remember the ribs is that there's one on each side for each thoracic vertebrae. 12 thoracic vertebrae, 12 ribs on each side. As I mentioned before, you can see this differentiating line here. This is costal cartilage that connects the ribs to the sternum. And this allows for a little more movement as that thoracic cage expands and contracts with breathing. Now, the second grouping of bones is called the appendicular skeleton. And these are the bones of all of the extremities of the body. So the shoulder and arms, and the hip and leg. So let's look at the limbs, the hip and the shoulder. Within the arm, we start with the shoulder. We have the scapula here, or the shoulder blade, as it's more commonly known. The clavicle, or the collarbone, and this attaches into the humerus. So the shoulder is made up of 3 bones, and there are a number of joints, from the sternoclavicular, acromion, the AC joint, acromion clavicular, as well as the glenohumeral, which we see, as most people consider, to be the shoulder joint itself. It's a little bit more complex than simply being one ball and socket joint. We come down the humerus, where we then find the bones of the forearm, the ulna, where we have the elbow point, and the radius on the thumb side. Within the hand, we then have the carpals, which are the 8 short bones within the wrist. And then we have the metacarpals, which are the long bones between the short bones of the carpals and the long bones of the fingers, the phalanges. The phalanges are the name given to the finger bones, but is also the name given to the toe bones. Let's look at the hip and leg. So the sacrum and coccyx forms part of the axial skeleton, whereas the ilium, ischium, and pubis form part of the appendicular skeleton. Here, where the joint meets the femur, we have that ball and socket joint of the hip. And as the femur comes down and joins the tibia, we also find the patella, which is a sesamoid bone. This is commonly known as the kneecap. The tibia is the larger of the 2 bones in the lower leg, and the fibula is the smaller, more lateral bone of the lower leg, where this comes down to form the malleoli of the ankle, or the ankle bones. In terms of the foot, whereas in the hand we have carpals, in the foot we have tarsals, and that is the name given to the 7 short bones of the foot. The metatarsals are the long bones which connect the short bones of the tarsals with the long bones of the phalanges, or toes. The skeletal system provides many vital functions for the body. Let's talk about support and shape. The skeletal system gives us our shape. It provides the framework for the connective tissues to connect, the organs to sit within, and for the muscles to attach to. It protects as well as supports the weight of all of these tissues and organs. In terms of protection, the bones are often shaped to provide this function. For example, the skull houses the brain and protects it within, the ribs protecting the heart and lung, the vertebral column protecting the spinal cord within it, and the pelvis protecting the bladder, intestines, and reproductive organs. Movement and muscular attachment. The bones provide the surfaces through which the muscles and connective tissues can connect bone to bone and joints to allow movement as they contract and relax, as well as biomechanical leverage. The bones also produce blood cells, both red and white, and platelets within the red marrow of the bone. But they also store. In terms of storage and mineral homeostasis, the bones store calcium and phosphorus. And when these minerals are required somewhere else in the body, the bones release these minerals into the bloodstream as part of maintaining that homeostasis we talked in our very first module.
We're going to use this illustration of a long bone here to talk about the different types of bone tissue and also general bone structure. So there are 2 types of bony tissue in all bones. We have the external, exterior, more densely packed exterior, which is called compact bone. And then what we can see inside here, where we have these spaces or holes like a sponge, what we call cancellous or spongy bone. Bones are also covered by this outer layer of connective tissue called the periosteum. This is so important. We talk about the importance of connective tissue. It plays a role in the formation as well as the nourishment of bone tissue. but is a really important attachment site for the soft tissues of the body. The muscles, tendons, those soft tissues blend into the periosteum to allow movement as they contract and relax. So let's talk in a little bit more detail about the compact bone. So as we said, it's more tightly packed, it's tougher, it has a tight packed network of bone cells and forms that extremely hard supportive outer layer of a bone. It gives the bone strength, and that along with the length and size of a bone gives it the strength to resist against compressive forces. It forms the external layer of all the bones in the body, including in a long bone, the medullary canal, or the shaft of the bone. This is what we call the diaphysis of a bone. Within the diaphysis, we also have the medullary cavity in the middle, and this is where the marrow is stored in long bones. Looking here at the cancellous or spongy bone, these spaces have a number of functions. One, it allows the bone to be strong, but also reduces the weight of the bone. If the bone was solid with compact bone, it would be much heavier than this combination of spongy and compact. You'll also see that within the bone, blood vessels, bone marrow, there are things stored and functioning within the bone that need space. So again, it gives a little bit of strength rather than being completely hollow, but also allows this network of vessels and marrow to be within the bone. Spongy bone forms the epiphyses, the ends of long bones. It is also the site of blood cell production in the red marrow. Bones are classified into 5 different types. There are so many shapes, sizes, and varieties of bones, it makes it easier to classify the bones based on their shape and function and the similarities between them. So the first one are the long bones, like the one we looked at in the last example. And this is where the bone is longer than it is wide. So here, for example, looking at the humerus, it's longer than it is wide. They're made up of both compact and spongy bone, as we've seen in the previous example. And they have the least material and weight, so they've got quite a lot of spongy bone in the middle of them. They tend to be slightly curved, as this increases the strength of the bone and the compressive forces that it can take. But it consists of that hollow shaft, which again helps to make it lighter, but stores that bone marrow that we've talked about. There's a variable number of extremities and shapes, as you can see here, just looking at the shape of the humerus heads versus the radius and ulna, the femur, tibia, and fibula. Short bones. So these are bones that are pretty much as long as they are wide, squarish, short bones. And examples of those are the carpals in the hand here and the tarsals, which we can't really see in this illustration, of the foot. They consist mostly of spongy bone, except at the surface, where there is a very thin layer of compact bone. Flat bones, like looking here at the scapula, also looking at the ilium and the pelvis. 2 reasons why they're flat. One, for muscular attachment, big broad attachments, given how mobile the hip and shoulder joints are, for example, so allowing for all of those attachments to support the movement. But they also have a protective quality. In terms of what they're made of and structure, they're composed of 2 thin and nearly parallel plates of compact bone with a very thin layer of spongy bone between them. So they tend to have that flat appearance. Irregular bones, complex shapes, different, variety. They have varying amounts of compact and spongy bone. Vertebrae are examples of irregular bones. Sesamoid bones. Now these are short bones, but the differentiator here is that these bones are embedded in soft tissue, in tendon. So an example here is the patella bone. It's important to understand the process of bone growth. gives you an understanding as to where the bones have come from, but also helps you understand the bone remodeling, which is something that you will come into contact with more commonly when working with clients. There are a number of key terms that we need to understand or mention before we talk about this process of bone growth. The first being the formal term for this process, which is ossification of the bone. We then have osteoblast. That is the name that we give to a bone building cell. So blasters build cells, osteoblasts. We then have osteoclasts. They clasp on to bone cells. They reabsorb bone and enable bones to be shaped or formed correctly, and also play a role in reabsorbing damaged bone cells, for example, in bone remodeling. Osteocyte, that is the name we give to mature bone cells. So let's talk about bone growth. And there are two types of ossification in the development of a human: intramembranosus, or more commonly, endochondral ossification, which is the means by which most bones in the body are formed, and the one that we'll talk about in detail here. But let's mention intramembranosus ossification. And this involves the replacement of sheet-like connective tissue membranes with bony tissue. These bones include certain flat bones of the skull and some of the irregular bones, and they start out as connective tissue membranes that are then calcified or ossified into bone. With endochondral bones, they start out as a hyaline cartilage model. So you can see that this model looks bony and shaped, but it is simply cartilage before the process of ossification starts. In a long bone, this hyaline cartilage model starts out as a diaphysis. Remember we talked about the diaphysis, that long part of the bone. This matrix then starts to calcify, this calcified matrix that we see here. And you'll see that calcification is happening at the diaphysis, not at the epiphysis, the ends of the bone. Cavities start to appear within this matrix as cells die. And this becomes what we call the primary ossification site. So the ossification starts and works outwards from here. Blood cells start to invade those cells, bringing nutrients, for example. Also bringing various cells that partake in the process. Osteoclasts start to break down some of the spongy bone and start to shape out that canal, that cavity in the middle, the medullary cavity where the bone marrow will be stored, in the diaphysis of the bone. Also, at the same time, we get this outer layer, this periosteum, starting to form. Dense, irregular connective tissue, which will allow the soft tissues as they develop to connect to the bone via tendinous attachment. Towards the end of prenatal bone development, the epiphyses, or the ends of the bones, start to calcify. Going to mention this epiphyseal plate here, this line between the epiphyses and the diaphysis, that long part of a bone. This is an important point because the growth will continue and the ossification will continue between the ends of the bones, between these epiphyseal lines. This is a process which is called appositional growth, or growth between the two epiphyseal plates or lines of the bone. These growth plates are key to bone growth, and if they are damaged or broken, for example, in an infant when they have a fracture, then this can affect the growth of that bone. So it's a really important part of bone growth. The bone lengthens as the diaphysis lengthens between the two epiphyses. And this hyaline cartilage at the epiphyseal plate is present until the bones are fully formed, which is at around 18 years for a female or 21 for a male, at which point that epiphyseal plate calcifies and becomes the epiphyseal line that we see in fully grown bones. Other factors of bone growth are hormonal. The skeletal system works in tandem with the endocrine system. Growth hormone, thyroid hormones, these have a real impact on bone growth during infancy and childhood. too much, too little, impact on the growth of the skeleton. Testosterone and estrogen also play a part in the physical changes and shapes of bones. For example, the female pelvis that widens during puberty. So let's move on to talk about bone remodeling. So bone repair. This process is happening whether at micro level, so those little cracks, little bone cell damage that's happening due to strength training in life, as well as on a macro level where we have, the bigger events like a fracture, a crack, a stress fracture, things like that. So there'll be an element of inflammation. Macrophage, for example, will come in and help in that process. Osteoclasts then come from the bone marrow, and they come and eat up, reabsorb any of those damaged cells that have been affected through the damage. Osteoblasts then come along from the bone marrow too and start to blast down those new or young bone cells. And we call this osteoid at this point, and it's made up of bone and collagen and other proteins. Osteoblasts are found on the surface of the new bone, and they regulate the passage of the calcium in and out of the bone. Once that bone cells have matured, they become what we call osteocyte, or mature bone cells within the fully formed and strong bone. So we constantly have this process of the old bone, new bone being laid down by the osteoblast, osteoid, which is that immature bone, and then that becomes old bone or osteocyte again. So this is happening, this remodeling on a constant basis. New bone, where the old bone gets damaged, osteoid, that immature bone, and as these layers and this process repeats and repeats, they become osteocyte or old bone.
So we're going to talk about 3 or 4 of the most common pathologies relating to the skeletal system that you'll see in your clinic. But if someone presents with a condition and you're unsure about it, first port of call is the GCMT contraindications list. So that's the General Council of Massage Therapists, and you'll find that on the references at the end. Always a good place to start for the latest information. If in doubt, get out or ask for GP referral. So the most common you'll probably come across is osteoporosis or osteopenia, which is this reduced density of bones. They may have more brittle bones, more common fractures, a history of fractures, frequent fractures. It can also present as vertebral compression, postural issues. Again, not something you'll see as red flags, but something a client will screen to you on their screening form. And we can absolutely treat these clients. We just need to be aware that their bones are less dense and we need to avoid bony prominences. Modify your pressure, although we should never be working at pressure that would damage bone. But I would be mindful about maybe working more transversely, working across tissue, transverse STRs, working compressions, teasing away from the bone rather than into bone. Just changing our mindset by understanding that the bones are more brittle in someone with this condition. Osteomalacia or rickets. Again, not something you're going to flag up, but something that someone would flag to you on their screening form. They can have bone pain, muscle weakness, difficulty walking or changes to gaits, flattening of the pelvis. So you can imagine someone with these conditions could really need some soft tissue work. But again, I would modify similar to that with osteoporosis. We don't want to aggravate the bone. We don't want to work into bone pain. Avoid the bony prominences and focus on teasing tissue away, working in with a pressure that feels good for your client. Osteomyelitis, itis, inflammation, bone pain. They may have a temperature, swelling, heat across the area. This is a contraindication and we should not work where there's osteomyelitis in a client. Scoliosis. Again, actually you will come across this quite commonly. People may have a congenital scoliosis, they may have had it from birth. Often it appears in the teen or in the early 20s in a lot of people. And this is getting a curved spine as seen from the front or back, so seen as a lateral deviation. The spine is obviously naturally curved, but this is curvature in the opposing plane. Your client may have had surgeries. They may have had plates inserted. Different clients have had different journeys when it comes to scoliosis. Some may only ever have had conservative means, no surgeries. We can absolutely treat these clients. They're not brittle. We should not fear them. And massage can absolutely help alleviate pain and help improve the mobility in clients with scoliosis. It can be quite a visual difference. The client can look taller after treatment. Soft tissue work can just be part of their ongoing maintenance plan. We're never going to fix or change or get rid of a scoliosis, but we can absolutely affect how that client feels, how they move, the freedom, and reduce the pain in their bodies with good soft tissue work.